All right, so this next section is going to be referring to the liver and the Tri-City organs. So we have this nice picture up here. We're going to talk about some of the issues related to the liver and the Tri-City organs. That's my way of affectionately referring to the gallbladder, the liver, and the pancreas, Tri-City organs. Anatomically, understand that all of these three organs empty their juices out of one hose. Okay, that's why I call them Tri-City. And we referred to it once before in another class that if you happen to be in Florida and the hurricane comes, and you're in Florida and you've got to get out of the one highway, that's going to be a problem. Everybody's going to be trying to get out and things can back up. And that's the design issue with this setup. I hesitate to call it a flaw, but I do, and one day I'm sure the lightning bolt will hit me right between the eyes. I'll get probably one of those Harry Potter things. But this is an issue, right? If you have a gallstone that sticks right here, that's going to cause not just problems with your gallbladder. It's going to cause all of these three organs to suffer. They can all become inflamed. They can all fail because of that. Just one simple little gallstone can cause that. Now, some of you do have an extra accessory duct out of your pancreas, about only 10% of you. But if you had a plug right here, you'd still get a hit on your gallbladder and your liver. Your pancreas would still be okay, though. So that accounts for some patients who show up that way. So I like to point that out when I look at this slide, is that anatomically there's a challenge with those Tri-City organs. All right, now let's talk about the liver for a few minutes and its inflows of blood. Physiologically, the liver has two inflows of blood, not just one. Okay, most of our organs have one inflow. It's the arterial blood, right? But the liver has two inflows. It has the hepatic artery, which is 25% of its inflowing blood, and it has the portal vein. Okay? The portal vein happens to be 75% of its inflowing blood. So the liver receives blood flow two ways. One for servicing itself for nutrition, oxygenation, and the other one is from the portal vein. Now, where is the portal vein coming from before it comes to the liver? What is it draining or absorbing? Okay? The portal vein is what's picked up all the nutrients from the gut. I was trying to lead you there with the absorbing word. Okay? The portal vein is getting all the inflowing nutrition and substances from the gut, and it brings it to the liver first. And that's physiologically very helpful. We call that first pass when we're talking about medications. So everything that comes in through the gut first passes through the liver via the portal vein. That's supposed to protect us. We have special cells in the liver called Kupffer cells. And those Kupffer cells are immunologic cells which help remove bacteria and pathogens and protect us. The same thing is medications. Hopefully you remember the first pass phenomena. When a patient takes a medication, the first thing that it does is go directly to the liver and part of it gets removed. That's why we have to give more medication if we're giving it by PO route as opposed to IV route, and that's because of the liver and the first pass phenomena. Okay, so two inflows of blood. Now, we have to talk about what is it that the liver does so that we can understand what happens when it fails. It has many jobs. It has to do with metabolizing and making sure that we have plenty of sugar. The liver can provide for us sugar, it can store sugar, and it can make sugar out of other things. So if you didn't eat breakfast this morning, you're still maintaining your blood sugar because your liver is releasing its stores of glycogen, and it provides for you sugar from its storage. If it uses all of that up, then it will start burning some of your body fat to create sugar for you. So your liver is supposed to be maintaining blood sugar for you, and it'll do it for a while. And in some people it doesn't work as well as others, but glucose metabolism and regulation is important, and the liver does that for us. Another important job is that it deals with the byproducts of protein metabolism. It takes ammonia, which is a really toxic substance, a byproduct of protein metabolism, and it converts it to something else. What does it convert it to? To urea. It converts it to urea. And what gets rid of urea? The kidney. All right? So if the liver fails, what lab value is going to go through the ceiling? The ammonia level. It's going to go very high. We will see that elevate in patients who have liver disease, end-stage liver disease. We'll get back to it shortly. If a patient has an elevated ammonia level, we're looking for what's going on with that. We think liver. Protein metabolism. The liver makes albumin. I've already told you that several times. I'm going to keep telling you that this semester. The liver makes albumin. So if the liver fails, what happens to the albumin level? It decreases. Why do we care? We need it in the bloodstream. Absolutely. It is albumin which provides oncotic pressure or pulling pressure in the bloodstream. It's what helps hold fluids there. So if the albumin level is very low, we will tend to develop edema. Okay? And what will happen to the patient's systemic blood pressure? It drops, right? We don't have the protein there to help hold the fluid in the vascular space. So albumin is critically important. The other protein that I like to bring up that the liver makes for us is clotting proteins. And if we don't have a healthy liver, we are going to have problems with clotting. Patient with liver failure is at risk of bleeding. All right? Which lab do we look at in relationship to bleeding problems with the liver? ProTime and INR. ProTime and INR. So if we have a patient in liver failure, they have a risk of bleeding because they're not making necessary clotting proteins. Right? Also, fat metabolism, well, we know that happens. If we're not having enough energy and we've gotten rid of our stores of glycogen, then it'll metabolize fat for energy. It'll do that. Vitamin and iron storage. The liver stores your fat-soluble vitamins, which are the A, D, E, and K. And vitamin K is important for clotting. Very good. And it stores iron for us. Another important job of the liver is that it metabolizes and detoxifies drugs, other things. So if we have a patient with liver failure, do they end up getting higher dosages of medication or lower dosages? They end up getting lower dosages of medication. And if they don't, they'll become toxic very easily. Last but not least, the liver creates bile, which is needed for emulsification of fat. Now, part of bile is bilirubin. And where does bilirubin come from? It comes from red blood cells. As red blood cells are broken down, bilirubin is released. Okay, it's picked up by albumin. It's taken to the liver for conjugation and excretion. So if we have a patient that has liver failure, what will happen to this process? It don't work. The patient's bilirubin level goes up, and what will we see in assessment? Jaundice. Very good. So this is just like a quick review of what the liver does, so that hopefully you'll understand if it fails, these processes aren't going to happen properly. All right. Disorders of the liver. Hepatitis. You can have a viral or a chemical hepatitis. Most people, when they think about hepatitis, they only think of viral. Let me give you an example. If you overdose on Tylenol, that will cause a chemical hepatitis and possibly liver failure. But Mary, how could you kill yourself with over-the-counter medications? You can do it. Don't do it that way. That is not a good way to do it. Yes, that's not a good way to do it. A lot of teenagers do that. They'll take 100, 200 capsules of Tylenol. It's not a good way to do it if you're trying to take yourself out. Yeah. Okay, so let's talk about the viral ones because that's more commonly what you're going to deal with or see. The hepatitis A, B, C, D, E, and more. For the purposes of the class, we'll talk about A and B. But C is on the rise and is very silent and is more dangerous than B, just so you know. And there is no vaccine for C. They're not even getting close. These viruses are so smart, they just keep mutating. It's like they know we're getting close to finding the vaccine and they change. I'm changing again. Okay, so key important things you should know about A, right? A is spread fecal oral. Got a letter. when I used to live in Ahwatukee from the Kyrene School District. If your child ate strawberries on this day, they may have been exposed to hepatitis A. That's what I said. Lovely. Now, it's not as much of an issue anymore because hepatitis A vaccines have become required for children. Okay? So it's not as much of an issue anymore. But at that particular time, and so I'm like, Jason, did you eat strawberries? Mom, I hate strawberries. So I didn't have to worry about it. But what if he did? What if he did? Then I would have to be watching for signs and symptoms of hepatitis. I wouldn't have to do anything that much more, really, because hepatitis A is not a killer. It makes you feel miserable for 6 to 8 weeks, but then it's over. You form your antibodies and that's it. 50% of you've already had it. Statistics show 50% of our American population has contracted hepatitis A, and 50% of us have antibodies for it. Where did we get it? Fast food. Yeah, fast food. And it's because somebody went to the bathroom, didn't wash their hands. Exactly. But do you see the signs in every bathroom? Employees are required to wash their hands. Yeah, I see those signs too, but I'm just thinking maybe somebody doesn't do it. I'm going to have you all broken to go into fast food, huh? It hasn't broken me yet, and I still keep teaching this, so I don't know.
So what are the signs and symptoms?
Signs and symptoms of hepatitis, whether it's A, B, C, D, E, or chemical, are the same. The patient can be jaundiced, and they might not. Right? The patient has anorexia. They throw up. Some of them get a rash. They don't feel well. So guess what? Sometimes hepatitis A is very subclinical. The patient thinks they got the flu. They got a fever, but this flu hangs on for about 4 to 6 weeks. They feel really crummy for 4 to 6 weeks. Not everybody gets jaundice. You ever had a flu that lasted a long time? If you have, might have been hepatitis A. Did your pee get dark and concentrated? And you don't know if that's because you're not drinking enough water, because you have a fever that makes you lose fluids. It's hard to say. All right, so hepatitis A is fecal-oral spread. Best prevention is going to be vaccine. Now, what if you wanted to prevent the spread of hepatitis A? We have to do teaching with the families. Good hand washing, good sanitary practices, very important. It spreads really easily too. Hepatitis viruses are very viral. Very viral. They spread very easily. Okay? Hepatitis B is blood, so is hepatitis C. They're both blood. And we as healthcare providers are supposed to be vaccinated against hepatitis B. Does that mean we should feel all comfortable? No. No. Some of us might not even have a titer that's high enough to protect us. And I'm bad. I haven't had my titer. I need to do that and make sure I'm protected. I've had all the shots, but never had the titer yet. I'm not supposed to tell you that, I don't think. Doesn't bode well for me, does it? So best prevention is to have the vaccine again, but we need to teach our patients. Let's say we have patients that are positive with hepatitis B. Knowing how it spreads, what do they need to be taught? Safe sex. Should they be telling their partners if they're positive for hepatitis B? Yeah. Oh yes. Oh yes, they should be. They need to provide protection. If it's a new exposure and the person hasn't been vaccinated, they can at least be offered hepatitis B immune globulin, HBIG. Okay? We can give that to try to protect people. That's giving passive antibodies so they don't contract the disease until we can cause their body to form antibodies actively using a vaccination, which isn't going to cause them to get the disease. That's what we hope. So with hepatitis B, be aware of bloodborne. Hepatitis C, bloodborne. How do we prevent it? Vaccine if we can. Is there a vaccine for hep C? No. We have to do good patient teaching. Don't share toothbrushes. Don't share razors. Needles. Yeah. Yeah, do condoms protect you from passing hep B? Well, maybe. Can they fail? Yes. It's better than nothing. There you go. There you go. But it's not absolute. Not absolute. Now, the thing with hepatitis is the liver has the ability to regenerate. There aren't many tissues in our body that we know that can make more cells. Maybe you've heard about people who've donated half of their liver to somebody else and then they grow it back. And the one that they've donated could grow its other half back. We need to study the liver more. Very amazing. So these cells can recover. So during that care period when somebody has hepatitis, we want to give them a lot of supportive care so that the liver can regenerate. All right, we talked about signs and symptoms. Maybe subclinical. Subclinical means we don't pick it up and figure out that it's hepatitis. Or they might not have jaundice, so we might not know. Nausea, vomiting, anorexia, fever, rash. Obviously, if they get jaundice, we're probably going to pick it up, if they got something going on with their liver. Symptomatic treatment and rest. Remember, the liver has to do a lot of metabolizing and trying to keep our blood sugar level for us. If a patient's got an inflamed liver, we want to keep them quiet. We don't want to have a lot of activity. We want to let them rest. We don't want to encourage their metabolism to be high. They might need supplemental glucose. Teaching and vaccination are issues. All right, cirrhosis. Cirrhosis is when the liver comes to a point that it no longer regenerates. It no longer is able to make new cells. What happens is the cells that are unhappy or diseased are replaced with fibrous scar. And when you lose those cells, you lose function. When you have replacement of scar, it's like a patch. It's like you put a patch in there, but it doesn't work. It provides no function or service for the patient. In fact, as those areas become diseased and they are replaced with scars, that can affect the ability to get blood flow through the organ as well, and can cause obstruction of blood flow through the organ. Okay? So cirrhosis means, oh boy, the tissue can't regenerate anymore. It's starting to form scars. So we got this liver that's not working well anymore. Common causes, alcoholism. You already know that, but don't knee-jerk that every patient you care for that's got cirrhosis has alcoholism, because it's not 100%. It is a high probability. It could be that they've had hepatitis long-term, and that's caused them to develop cirrhosis. Or it could be that they have a chronic obstruction of their biliary tree, the hose that drains out all the bile and the gallbladder stuff, and the pancreas becomes damaged and obstructed. That can cause cirrhosis as well.
Mary?
Yes?
People who have cirrhosis or even like hepatitis or liver failure, any of those, can they get a liver transplant? And things,
Yeah.
so any of those ones?
The patients that have liver failure can get a transplant. If they're alcoholics, they got to be off the booze for 6 months in most states. They got to be able to show that they're in recovery. And even a patient who's positive with hepatitis could get a donation of a liver from somebody else that's positive with hepatitis. They can do those kinds of things if they want to. I mean, it's just like me. If my liver goes and the only liver I can take is from a donor who's positive with hepatitis or HIV, I would still consider it. Okay, I'm going to get that liver, I'm going to live. I'm going to contract whatever they had, whatever the donor had, but I'm going to live. You know, they deal with those kinds of issues. But your question was, if somebody has that, are they eligible for a transplant?
Well, does a transplant cure that, or does that cirrhosis, I mean, do they totally remove the liver, or do they just put them together?
A new liver will be a new liver. You got to ask yourself what caused the cirrhosis. If the person is infected and they get a transplant, the organ will become infected. Does that make sense? The same as if I'm getting a liver transplant from somebody else and that organ's infected that they give me.
So the liver transplant may not fix the issue.
It depends. It depends on what caused it. If they took a Tylenol overdose and that caused their liver to go, and we give them a transplant, that's fine, unless they continue to Tylenol overdose. If it's because they have the virus, Hep B or Hep C, no. Over a time period, that organ will become infected as well. Because once you got a virus, you got it for life. You don't get rid of viruses, no matter what they are. Okay, so I want to go through some of the things that you see with liver failure so that when you take care of these patients, you'll remember this is what you're going to see and this is why. So one of the things that we see with liver failure is that the patient develops portal hypertension. And what that is increased pressure in the portal vein. Remember, 75% of the inflowing blood to the liver is from the portal vein, correct? Okay, that's all of the blood flow from the gut that's picked up the nutrients and it's taken it to the liver for processing. So if the liver's failed and it's obstructive, that's all going to back up. Portal hypertension, there's more pressure in that vein than in the organ. It's trying to get in there, but it can't. Now, I'm not talking about this kind of hypertension. I'm not talking about systemic blood pressure. I'm talking about increased pressure in the portal vein. And when we get that, stuff backs up. The patient will develop varices, right? Hemorrhoids, esophageal varices, the spleen's going to get enlarged. All of the blood backs up in the venous system. That's what occurs because of portal hypertension. Again, don't get confused. It's not systemic blood pressure that goes up at all. It's increased pressure of the portal vein. So the patient will develop varices, and because of that pressure on the venous system, fluid will tend to leak out into the cavity, into the peritoneal cavity, and the patient will develop this large belly. Remember, ascites is fluid in the peritoneal cavity. Makes the fluid wave on assessment.
Tell me again what varices mean.
Varices means the veins are distended by increased pressure, and those veins start to get really big, and they start to have these windy sort of path on them, and they can rupture really easily.
Is that like the ones in the picture?
Yeah, it's a general idea, except it's happening internally as well, right? Treatment for portal hypertension and ascites, sometimes we'll be draining the fluid off of them. That's called a paracentesis. We'll talk about that more in the next class. Shunting, it should be PV, it says VP there, it should be PV, peritoneal venous, meaning we put a tube in the peritoneal cavity where the ascites is, and we trail it up into the vena cava area, so when the pressure builds up here, it shunts the fluid back into the venous system. Those work really nice for a while. They usually plug up after a while. So if it's working, the patient's belly's small and their blood pressure's good. Right? When it clogs up or it fails, their belly distends back up and their blood pressure drops because you're not redistributing the fluid. Surgical shunts just mean that, you know, we can't get the blood flow in, so we could take that portal vein and hook it right up to the vena cava. Doesn't matter, the liver's not working anyway. But that's a hard surgery for a patient to go through. So that's why they created TIPS, trans-intrahepatic portal shunting. Trans-intrahepatic portal shunting. They do it in interventional. It's all in the cath lab. They just use catheters where they cannulate the portal vein and the hepatic vein, which is the outflow of blood from the liver, and they burrow through and they put in a tube, and they bypass right through the liver. So that takes away like a lot of the ascites, portal hypertension issues. So if you hear of a TIPS procedure, that's the picture that you're seeing right here. Trans-intrahepatic portal shunting. Just letting you know some of the things they do to manage it. Okay, another thing we see with liver failure is jaundice. Why do they get jaundice? The liver does not have the ability to conjugate and excrete bilirubin. Therefore, we see it deposited into the skin. It's called jaundice. The other adjective that you'll see on the patient's chart is icteric. I-C-T-E-R-I-C, icteric means jaundice, okay, or bilirubin deposit in the skin. All right, with liver failure, we're not going to have production of critical proteins. We talked about that before. Albumin, which is really necessary for fluid maintenance in the vascular system. If we have a low albumin, the fluid, the water is going to go out into the tissues, right? And it's going to stay there. It's not going to be pulled back into the vascular space. Protein, like albumin, provides for us oncotic pressure, pull pressure, to get that fluid back into the vascular space. So let me ask you, what do you think happens to the systemic blood pressure in any patient with a low albumin? It tends to drop. That's right. Because of the albumin, because of the fluid shifting. How do we treat it? We give what they're missing, albumin, right? That's why I always get frustrated with the doctors. They come around, I'm like, my patient's got a blood pressure of 90/50. It's a liver failure patient. They're here because of fluid management problems. What do I expect the order? I expect them to order albumin because they understand liver failure. But instead, they give me an order for 500 cc's of normal saline. Guess what? That's going to help their blood pressure for a few minutes. And then where's all that normal saline going to go? Right into the tissues. Then I'm going to be calling them again. Well, now will you give me albumin? Please. Nope. Another 500 cc's normal saline fluid challenge. I'm going to go off in the corner like this. I'll be calling them again in a half hour. Blood pressure dropping again. Now will you give me albumin? This is what scares me.
So by this point, aren't they like having like hitting edema?
Yeah. Oh, definitely. And the only thing that's going to make that fluid go back into the vascular space is albumin. Exactly. Some amount of diuretics will help with that. But what is it that restores the fluid balance? You've got to understand those normal physiology. That's why I try to tell you about that in that fluid lecture, right? If you don't have albumin in the vascular space, you're gonna be losing all of that fluid to the tissues. Best way to restore what's wrong with this patient is give them what they're missing. Sooner the better. Patient may have issues with bleeding. We may have to give them what they're missing, clotting factors. We do that by giving them fresh frozen plasma or vitamin K. We give them what they're missing.
What's the ABN?
Abnormal. Fluid regulation is ABN, abnormal. I'm not going to go through all these different treatments we can do for bleeding problems. I'll just let you know that if a patient has esophageal varices and they're in liver failure and they start to bleed, you're going to have a really bad day. It's really hard to get them to stop bleeding. They don't have clotting factors and those vessels are just weeping fluid all. Ugh. It's very much a challenge. So make sure you got your standing orders for blood. Type and cross your blood. Make sure it's ready, right? Make sure their coagulation stuff is in order. If you need to give them aquamaphytin, that's important. All right, hepatic encephalopathy is end-stage liver disease. So if you're taking care of somebody who has hepatic encephalopathy, that should tell you that they're probably not going to get better. They're going to be in this state of chronic illness until they die. This is like end stage. Now, what does that mean? Encephalopathy. That is a disease process of the liver that affects the brain. That's what hepatic encephalopathy means. So, the piece of liver failure that causes this is the elevation in ammonia. Ammonia is very toxic, neuromuscular-wise, especially neuro-wise. So that when the ammonia level goes up, the patient gets very confused. And if we don't take care of that, the patient becomes comatose and then the patient dies. Right? So hepatic encephalopathy is end-stage liver failure. How do we know? The ammonia level will be high and the patient will be neurologically abnormal. As the ammonia level starts to drop, they become uncoordinated. One thing you could have them do is write their name on a piece of paper every day, and as the ammonia level goes up, they'll be less able to do it. Or even if you're walking them around, they become less coordinated. And then one day you go in to see them and you can't wake them up. That's examples of what happens when your ammonia level goes up. So how do we treat it? We try to get the ammonia level down. We use lactulose. Okay, you should have heard about that by now, right? That's a laxative. They use it in the nursing home to make sure that the patients are going every day so they can write it in the BM book. Lactulose given, BM, lactulose given, BM. But in this patient, they're getting it for a different reason. This patient gets lactulose to lower the ammonia level. It's very important. Can we hold it? We're unhappy because the patient's having diarrhea. Can we hold it? No. We have to speak with the physician and say, is it okay to lower the dose? The ammonia levels today, can we lower the dose? The ammonia level's okay today. Can we lower that dose a little bit so the patient doesn't have so much diarrhea? What happens if we just hold it because the patient's having too much diarrhea? The ammonia level goes up. A lot of nurses don't know why they're giving lactulose to a liver failure patient. I see it all the time. That's scary. Other things we can do is remove the cause, or there is a treatment now where we can it's not like dialysis, but there is a process where the patient can be treated by a machine to remove ammonia. Okay? So I was at one of the local hospitals with a student And we got word from the nurse that we get to put an NG tube in. We were both excited, right? And the nurse says, this can be easy. The patient's not even with it. You'll be able to sink it right down and be a piece of cake. So students are like really excited. It's going to be an easy NG tube, no problem, right? Okay, so we get all of our supplies. We go to the room, and we walk in the room, and the patient looks like he's sleeping, and the wife is sitting next to me. We're like, hi, we're this, that, from MCC, and we're going to put the NG tube in for your husband and everything. And she's like, okay. She goes, I don't know what's been going on with him. I tried to tell the nurses last night. Would you believe that last night he was alert and oriented? He was completely talking to me. Everything was fine. He's been dealing with this liver issue for a while. And was having problems with his blood pressure and stuff, so we came in. But now I can't even wake him up. I'm really worried. The nurses, I've been telling the nurses since last night that, I'm really worried. His tummy's all distended. He didn't come in like that. And now I'm really worried. And I'm like, I'm not as excited about putting the NG tube in. And I start asking questions. So what happened yesterday? Are you serious? He was really alert and oriented? She goes, oh yeah. Like dinner time last night, he was fine. He was talking and everything. We were getting along. We were thinking he's going to be going home. And then, his belly started getting distended, but nobody was really worried about it. And then he started getting confused last night. I went home. I come in this morning, can't even wake him up. She said, I'm afraid. Something's happened here. What do you think I'm thinking? The ammonia level is up, all right? So we put the NG tube in. It was a piece of cake. It was like the perfect student NG tube for the first. It went right in, no problem. We have an order to put it to low continuous wall suction. We hook it up, and what comes out of it is black. 1 canister. 2 canisters, 3 canisters fill with black. Belly goes down. We see that. The student's like, oh my gosh, I can really see the belly's going down. I'm not thinking about that. I'm thinking about something else because I understand the patho for this patient. What was in that belly? Blood. And the sad part was, the wife even said to the nurses, she said, I told him that I was afraid he might be bleeding. I'm like, well, it looks like you may have been right. It looks like you may have been right. She said, that's old blood stuff, isn't it? I said, well, I would have to test it to be sure. And she said to me, is he going to wake up? Well, I couldn't answer that question, could I? I said, do you want everything done for him? Do you want everything done for him? And she said, well, I don't know. She said, we know that this was a chronic illness and it could take his life at some point. But my discussion went from, let's put in this NG tube, this is really cool, blah, 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 to end of life. End of life discussion within a matter of a few minutes. Now what scares me is that problem happened early in the evening the night before. And here we are, 11 or 12 o'clock the next day, dealing with it. What got missed? Assessment. And knowledge of patho, right? If you understand what a disease can cause and what's going on, you'd be thinking about it already. So, went to the nurse. I said, we need to call the doctor. Oh, did you get the NG tube in? Uh-huh. Great. We need to call the doctor. He's comatose. She didn't know why. I said, I'm concerned that he is comatose because his ammonia level's high. She looked at me like, what? I said, no, really. Where's the charge nurse? We need to call the doctor. This lady needs to be given all options. If she wants everything done for him, he needs to be moved to a hospital where they can do this new process to lower the ammonia level. I don't even know how high it is. Well, they ran it. It was about 350. It's supposed to be in the 40 range. So, the wife is like pulling me in the hall. His ammonia level is like 350. I said, that's really high. She said, I know. She said, is he going to make it? I said, I can't tell you that. Do you want everything done? And she said, well, I don't think that he would want us to go to extreme measures. And I'm like, well, then you have your answer, but I can't, I don't have a crystal ball. I said, but that's really, really high. And so the next day we came in for clinical, he wasn't there. He passed, right? It killed him. Now the question is, would he have died anyway? Eventually. Did it have to be then? I don't know. I don't know. But is it a story I should tell you? Yes. Because did it have to happen that way? No. And what was missing? Assessment. That somebody was listening to the wife. She was there. She had the knowledge. She knew that his belly got bigger. She knew that he could have been bleeding. She knew that something needed to be done. She saw his changes in level of consciousness. The nurses missed it. Interesting, isn't it? If you know the patho, you can be mighty powerful. Okay?